for Senator Jensen to move the bill. Okay, and so Senator Wickland will move Senate File 1575. Senator Pratt, please proceed.
Thank you. Thank you, Madam Chair. Well, first of all, let me just thank my co-authors, Senator Wickland, Jensen, Rosen, and Dietzig, for their support on Senate File 1575, which modernizes our health record statutes to allow safe and more efficient exchange of medical information for treatment, payments, and operations. The Minnesota Health Records Act was originally passed over 30 years ago, before the proliferation of PCs, the internet, and electronic health records, and before federal rules govern protected health information. The HRA has served Minnesotans well, and I want to honor that record with this bill. I don't want to, excuse me, I don't want to fix what's not broken. Senate File 1575 is a reasonable modification that will lower healthcare spending, reduce redundant procedures, and improve quality assurance at several points within the treatments, payments, and operations flow. There appears to be a lot of misinformation about what this bill does and does not do. We will not be repealing privacy provisions that protect Minnesotans. There will still be provisions defining when information is permitted to be transmitted, to whom, and for what purpose. This does not allow any sale of information that is restricted today, and does not lift any restrictions requiring permission for data to be used as part of research. This bill simply allows our healthcare system to work more efficiently and allow patients to have appropriate access to their health records when they need them. Madam Chair and members, people expect their health records to be used and disclosed as necessary to treat them. To bill for treatment, and quite honestly, in some extent, to help the clinic operate more safely. And with that, Madam Chair, I would turn the testimony over to Ms. Huppert.
Welcome to the committee. Please state your name and proceed.
Thank you, Madam Chair and members of the committee. My name is Erin Huppert, and I am here on behalf of Allina Health and the many organizations who support Senate File 1575. Senate File 1575 really is about patient care. It's about a reasonable change to a current law that no longer works for patients, their families, and their care teams. It would allow us to share clinically appropriate information for only those three specific reasons that Senator Pratt mentioned: treatment, payment, and healthcare operations. Now, I think the argument for why treatment and payment are important are pretty straightforward. Patients want providers to be able to treat them, and they would like their health plans to pay the bill. So what I would like to do today is talk a little bit about why healthcare operations are so important and why they are so important to this bill in particular. Healthcare operations are defined by federal HIPAA privacy rule. They aren't any possible use imaginable. They are specific, and they are limited to the activities that support the core functions of treatment and payment. So I thought I'd give you just a few examples of what would be considered healthcare operation. It would be providing claim information to the MCHA board so that they can administer the state's reinsurance program, which was just passed this week off of the Senate floor. It would be working with our academic institutions to provide medical training programs for the next generation of healthcare professionals. It helps us analyze our supply chain and identify drug shortages. We did this pretty recently when the Hurricane Maria hit Puerto Rico and disrupted the supply of saline. And it really includes things like mailing billing billing statements to patients, as proposed in Senator Drahan's bill, which is on the agenda later today. So for these specific activities, a provider or a health plan cannot use or share all of the patient information available. Under HIPAA, they can only use the minimum amount of information necessary to complete that specific activity. And should that provider or plan elect to contract with a vendor to complete the activity, which is already permitted today under current law, that vendor would also only be able to use the minimum amount of information necessary to complete the then both the provider and their vendor are subject to HIPAA's compliance and enforcement activities, which include criminal and civil penalties for violations. So why is it important to include healthcare operations in Senate File 1575? We would say it's because HIPAA recognizes how important these core functions are to the provision of healthcare. I would also argue that you as legislators recognize the importance of healthcare operations, even if you didn't recognize what they were on the outset. There have been at least 25 bills referred to this committee this session alone that have healthcare operations implications. So we are working within healthcare operations today. We will continue to work in healthcare operations if this bill is passed. The HIPAA privacy rule generally prohibits a covered entity from using or disclosing protected health information unless it's authorized by the patient, unless and except where this prohibition would result in unnecessary interference with access to quality health care. And that essentially is what is in stark contrast to the Health Records Act today. Madam Chair, members of the committee, we are seeking in Senate File 1575 to be able to carry out the core functions of payment and care delivery in a way that meets today's expectations by our patients and our families and your consumers. In your packets, there should be a letter of support signed by many organizations who come before you on a regular basis. This diverse group of stakeholders includes providers, patient advocacy groups, finance, labor, the business community, and I hope that that illustrates the broad support for this bill. Thank you for the opportunity to testify today.
Members, we will save questions for after we have heard list of testifiers. So Mr. Mark Buermann, prior late list is Bentley Brase, followed by Twila Brase, and Mr. David Feinwachs. And members, we have requested that everyone keep their testimony to 2 minutes. I'm sorry I did not announce that earlier. We've had a number of requests and we want to give members time to flesh out their concerns about this bill. Mr. Buermann, please state your name and proceed.
Thank you, Madam Chair, members of the committee. My name is Mark Buermann, and I support Senate File 1575 because Minnesota residents deserve the best health care possible. Our complex privacy laws make that extremely difficult. I've navigated through Minnesota's healthcare system and can only share a few of the many examples I've experienced through that time. I've maintained my health care in Burnsville at a clinic for 30 years, but weakness in my legs forced my doctor to refer me to out-of-network specialists. After numerous tests and exams at various facilities, I was finally diagnosed with a rare form of ALS by the University of Minnesota, which was later confirmed at the Mayo Clinic. I'll never forget all the time and effort it took driving around through Minnesota's winter to gather my medical records for that first appointment at Mayo because it took more time than my actual appointment. That's just not how our healthcare system should work. I'm now enrolled in a clinical trial in San Diego where I get lumbar injections every 4th Monday. This has really opened my eyes to see how good we could be, still while protecting the privacy of patients with the national HIPAA standard. One day my doctor in San Diego called to tell me he was concerned about my heart and wanted my primary doctor to review some of the records. Within minutes, copies of my EKGs were sent to me through email. However, when I called my clinic in Burnsville, they could not accept my email with my medical records, citing our privacy laws. At that time, I was left wondering, could our Minnesota privacy laws have cost me my life? Ironically, I have a cousin in Northern California who's experienced similar weakness in his legs. His neurologist asked if I'd be willing to share a copy of my genetic report to help his diagnosis. Of course I would, and with one phone call, I'm able to coordinate with my coordinator in San Diego to get my records transferred to San Diego. I still had total control, but able to transfer records in such an efficient manner. My doctor once told me here in Minnesota, he said a correct and timely diagnosis is so important because many treatments are now available. Yet those cannot be prescribed without the proper diagnosis. Delays that are created because of our complex privacy laws are just not acceptable and the residents of Minnesota deserve better. It is time for us to join the rest of the country and pass this bill. Thank you.
Thank you. And next, Mr. Bentley Graves.
Thank you, Madam Chair, members of the committee. My name is Bentley Graves with the Minnesota Chamber of Commerce. I appreciate Senator Pratt for bringing this legislation forward, and I'm appreciative of the opportunity to testify. For our members who are employers who offer health benefits to their employees, healthcare costs are a significant concern and have been for some time. But often when we embark upon these conversations about how to bring costs out of the system, how to bring costs down for employers and those paying the bills and their employees and consumers, it often comes down to, an us versus them approach. Somebody's cost is another person's profit. And discussions about costs often come at the expense of someone. But that's not the case with this bill today. This bill today is, as you know from a letter that's in your packet, supported by over 60 groups within the healthcare community, certainly employers, the Chamber and the Business Partnership, but hospitals and physicians, but more importantly from a number of patient advocacy groups. Those folks that live and move around the healthcare system every day. And that's because this bill would do two important things. One, it would bring costs out of the system, unnecessary costs and duplicative tests and rescheduled visits and unnecessary procedures. But it would also lead to better outcomes for patients, allowing patients to move more seamlessly and effectively and efficiently through the system, as you just heard the last testifier say. So this is a rare bill that receives support from all corners of the healthcare industry, all players in the healthcare industry. But importantly, not just bring down costs, but will improve outcomes for patients and provide better coordinated care for those patients. And so with that, Madam Chair, I'd ask for your support. And again, appreciate very much the opportunity to testify. Thank you.
Thank you. Mr. Graves. Next, Twila Brase, Mr. David Feinwachs, and then Mr. Rich Neumeister. If a page could come to the table. Welcome, Ms. Brase.
Thank you, Madam Chair, members of the committee. My name is Twila Brase. I am a registered nurse and president and co-founder of the Citizens Council for Health Freedom, a national organization located here in Minnesota. I have a packet of 3 handouts, including this winners and losers document, and I'll share 3 concerns about this bill. First, Senate File 1686 adds broad exceptions to our consent requirements. Within your packet is this definition of healthcare operations, for example, the actual definition. Healthcare operations is a 400-word list of at least 65 business activities, many done by various business associates who could be offshore and outside of U.S. law. Practically speaking, this bill makes consent requirements the exception in Minnesota. Thus, patient consent would rarely be required for disclosure and use of patient-identifiable data. Unlike Minnesota law, the permissive HIPAA rule leaves patients unprotected. As David Brailer, the first national coordinator of health IT said, quote, "You can't force a covered entity to give your data to someone you choose, and you can't stop them from giving it to someone they choose," end quote. Supporters claim eliminating consent will improve treatment, but our law's exceptions already allow records to be shared in an emergency and between related facilities for current treatment, which you can see in the bill before you. Furthermore, patients can sign a consent form as they've done for decades. Second, the proposed change is huge despite its few words. It replaces Minnesota's protective law with HIPAA's permissive data sharing rule. Now here is the Mayo Clinic's Notice of Privacy Practices. If passed, 3 of the red items on Mayo's form disappear, and patients won't be able to stop that data sharing. Third, HIPAA's state preemption provision allows Minnesota to have a better than HIPAA law, a law that protects patients from HIPAA. But this bill neuters our protective law. It's a data grab that also eliminates the patient's right to sue for these new authorized intrusions. This bill is all about money. United Health Group's Data and Healthcare Operations Division, called Optum Insights, had 2017 revenue of $8.1 billion. Without consent requirements standing in their way, there is much money to be made, including profits from using confidential patient data to control doctors and deny access to care. As I think the the recent decision showed. Thus, we oppose this bill and are pleased to see also that the Center of the American Experiment opposes this bill. Thank you for this opportunity to testify, and I'm happy to answer any questions.
Thank you, Ms. Brase. Next on our list, Mr. Feinwachs. And
My name is David Feinwachs. I reside in the city of St. Paul. I am here today sharing with you my views. I represent no constituency. I am an attorney and I have some background in the healthcare arena for some number of decades. And I have some knowledge of this issue, having worked in a number of areas related to it. And first of all, let me begin by saying this. I don't think anyone contests the right and the necessity of patients being able to move their medical record information for their effective care and treatment, and to make sure that any third-party payer who might owe money for that treatment pays in a prompt and efficient fashion. Minnesota's electronic health care record law, Minnesota's medical record law is not archaic, it's prescient. We passed a law that protected the citizens of our state long before the issues of data harvesting, Cambridge Analytics, and other things which now concern people and so terrifies the public came along. As Ms. Brase, the previous testifier, pointed out, one of the essential differences between what you're asked to do now and our current law is that if someone releases information without your consent, you will no longer be able to sue. The language about suing is still left, but consent is no longer required. This is important because some years ago, this information was released under HIPAA, legally under HIPAA, to bill collectors who misused it. A suit was brought by our Attorney General using the Minnesota law, not HIPAA. The main issue that people, I think, are concerned about, and certainly what I'm concerned about, is the business operations exception. That is an exception that's big enough to run a freight train through. I don't want my medical records used for business operations exception purposes without my consent. And when I say medical records, I'm talking about medical records, not name, address, phone number, amounts of money owed. I'm talking about diagnosis, prognosis, medications, the most intimate form of information. I prefer that this information not be given to a bill collecting company without my consent. Or, as one of the previous bills alluded to, if I seek some drug, I don't want to be bombarded with robocalls offering me the drug that I consulted with a physician about just the day before. So I think it's important that that part of the law be recognized as essential. There are problems with electronic health records. Much of Minnesota's electronic health record system is not interoperable. Some of that is due to less than perfect electronic and computerized stuff. Some of it is due to intention, because keeping people within healthcare systems is facilitated by having non-interoperable medical health records, and that does in fact need to be dealt with. But repealing Minnesota's private law on a wholesale basis like this is a bad idea, and I ask you to reject that notion. Thank you.
thank you, Mr. Feinwachs. Mr. Neumeister.
Madam Chair, for the record, my name is Rich Neumeister. I've been around a long time dealing with health records issues for a number of decades. Voiding Minnesota's strong health data privacy protections slays Minnesota's robust right to consent, where your most sensitive health data shall go. The attempt by the author is to do away with one of the best health data privacy protection rights in the country and place it with parts of the HIPAA regulations. Important to understand the premise, as some other folks have stated, that HIPAA, a federal regulation, sets a minimum floor of privacy protections and rights and allows us, the states, to be more protective of our information and provides you with more rights. Our current law assures you have control where your most sensitive data goes to, for, and what purpose. For example, do you want your mental health records to go somewhere else, or to be accessed by someone else that maybe there's no need for that information to be shared? Slapping down Minnesota's provision jeopardizes your privacy to where your health data can be widely disseminated and be used for purposes without your knowledge and consent. Who decides where, for what purpose, and to whom your personal health data is used and dispersed? You or the business and health interests? Instead, what is proposed in this bill is about a deletion of about 13 words of current law and replace it with some 20 words referring to a federal regulation. As I've testified in previous committee on a particular bill here, the regulation is pages long, and I'm sure some of you as Senate members have not read and understand what that regulation does. This regulation, with its broad language and definitions, encompasses many activities that many people are not familiar with and allows health data to be strewed about, which individuals may want to control and not easily being strewn about. To be clear, can there be changes in Minnesota law to accommodate concerns and issues? Yes, but not in this manner. Trading this bill for the loss of our state's protections is a bad exchange. If this proposal, along with others, can be discussed in a rational and comprehensive way, it should be better for us. And I think, Madam Chair and members of the committee, as you know, another legislative body did take a look at some of those issues. They looked at how can state law deal with the wishes of an individual patient to not have certain sensitive data be shared with others. How coordination of care, how can penalties and rights for parents be more enhanced? These are just some of the things that have been discussed. Minnesota has a comprehensive law. We should not lower our standards. Do not abrogate Minnesota's privacy consent provisions.
Thank you, Mr. Neumeister.
Thank you.
Now, Senator Pratt, responding to the testifiers, then we'll go to Ms.
I have to take exception with Mr. Neumeister challenging my intent on this bill. My intent is not to put patients' data at risk, and I take great exception to that. This is to make sure that our patients are being treated in a manner that, as Mr. Buermann testified, is in their best interest. And this is not for the Senate to come in and question anybody's intentions along those lines.
Thank you, Senator Pratt, and no one should question the senator's intentions. I know Senator Pratt to have worked very hard on this and to be moving this bill for significant reasons, and so I apologize that you came before this committee and was spoken about in this manner. And to members of the committee, I'm sorry, we have completed the list of testifiers.
She's my phone friend.
Okay. If Senator Pratt wants you at the table, you may be at the table. To Senator Klein and then Senator Abeler and Jensen. Senator Klein.
Well, thank you, Madam Chair. Thank you, Senator Pratt, for bringing the bill. This is a fundamental and essential bill. This is really the question of the age, not just for medical delivery and medical data, but for data privacy across all spectrums. The medical data that we gather when I see patients at the hospital has value to me, and it has value to the patient. And I can attest that if your bill passes, the direct clinical care that I perform will be expedited, it will be more efficient, it will be better, it will be cost saving. So for those reasons I applaud it, but it is counterbalanced, as with all data in today's society, with the fact that that data then has value to other entities, both healthcare delivery entities, and then also, as people have alluded to advertisers and outside interests. And how do we find that perfect balance? I support your bill. I've read the definition of operations provided by Ms. Brase, and I agree that it raises some concerns. So I don't think that this issue, I don't think we'll ever be fully done with this issue in coming sessions and in a rapidly changing world where data is the new product. But for now, I do support your bill. Thank you for bringing it, and I think it'll do good for patients.
Senator Jensen.
Thank you, Madam Chair, and thank you, Senator Pratt, for bringing this bill forward. Obviously, private health information is it's uncomfortable for everybody, and yet we're held to a high standard. In the last 2.5 years, it seems like we spent so much time trying to reduce costs, use the dollars wisely that we have, avoid duplicative services, things like that. I was wondering if we could have Ms. Erin Huppert Could you just sort of walk us through like a real life example of where not being able to do what you think we should be able to do does indeed cause a duplicative service, perhaps an imaging test like an MRI or a CAT scan, just so that everybody on the committee and in the audience would understand how easily these things happen and what we're trying to do in terms of connecting the dots.
Ms. Huppert. Thank you, Madam Chair, Senator Jensen. I think the best example that I could provide is in the emergency department. And I would note that the current exception to the consent requirements applies to emergencies only, not the emergency department. And then I think we can all appreciate that there are several patients who will come to a department, emergency department that maybe doesn't meet the threshold of an emergency itself, who will come in and be seen for, say, a heart issue. And they will have said, I happen to have been at another facility outside of my current provider system, and I had a stress test done 2 months ago. What happens today under current law is if the provider where the patient is at in the emergency department says, is it okay if I contact your provider and get a copy of that stress test? We then reach out to the healthcare institution that owns that holds the record for the stress test, and says, we would like to see a copy. The patient is presented before us. We'd like to see what the results of that test was. If that second provider can't confirm that they have a consent on file to release that information, then they can't release it to the emergency department until they have a consent on file. And so generally that means that there's a faxing process in place. The emergency department can say, I have essentially a representation of consent. I have virtually a permission from the patient that serves as consent to share that information. But there is still a processing timeline that takes place for us to be able to ensure that that is in place. And I think, in lieu of that, it is easier and sometimes provides more peace of mind to the patient to just replicate the stress test at the emergency department instead of waiting for the paperwork to follow through the process and then have that test sent. Senator Jensen.
Thank you, Madam Chair, and thank you, Ms. Huppert, for sharing that example. My impression has been that even opponents of this bill don't want to see their medical care compromised because we have a system that isn't facile in exchanging records. My understanding also is that 48 out of 50 states allow HIPAA to be the floor, if you will, for medical record exchange. Is that correct, ma'am?
Ms. Huppert.
Senator Jensen, for the purposes of treatment, payment, and healthcare operations, that is largely the case, yes.
Madam Chair?
Senator Jensen.
Madam Chair, Senator Pratt, I'm uncomfortable with releasing any more information than is necessary, especially in regards to, if you will, and I don't mean to demonize anyone, but oftentimes I think we have government departments and agencies that want information, and they don't want it for the direct benefit of the patient's care. They want it to examine, mine the data and see what they can learn, especially I think departments of health and human services. We have the advanced payer claim database that we've already extended, so that I feel like we've given both Department of Health and DHS opportunity to get information that way. Senator Pratt, I was wondering if you'd be willing to allow me to, I shouldn't say allow, I guess I have the right to do it either way, but I would like you to look at this amendment that basically
Senator
accepts.
Jensen?
Yes, ma'am.
We have a really hard time stopping you. I don't want to do stuff, so please proceed.
There's so many warm fuzzies in this committee that I just love coming here. I come here on Saturday afternoons just hoping that Senator Benson will show up. So anyway, Madam Chair, I have Amendment A1 that I would like to move, and that basically provides an exception that we would not be releasing health records to DHS or Department of Health, and that a provider must not refuse to provide healthcare services if a patient does not consent to authorize it.
And Senator Jensen, we have to distribute the amendment pages and to the author first.
I move the A1, Madam Chair.
Okay, we're going to wait for discussion until the author has a chance to receive the amendment. Senator Pratt to the amendment.
Madam Chair, I was just reviewing, Ms. Huppert, she has a couple of questions to address to the amendment.
And Ms. Huppert.
Thank you, Madam Chair, Senator Jensen. I think I'm conferring with Senator Pratt, and our one area of question applies to both sections of your amendment. Under the first clause, we're wondering how that works for the current disclosures we're required to provide community to both the Department of Health and the Department of Human Services. So I'll give you an example for each. We're required to disclose information to the Department of Health under SWORMs for quality reporting, and to the Department of Health, their payer. So we would need to be getting that information for the purposes of payment, since Minnesota Care and medical assistance enrollees are our patients. So as long as we can address those particular areas for which we already have to disclose information, I don't envision a challenge with the amendment. And then with section 2, I just would wonder, or would like some clarification on how that works if it were amended to the bill, since we would no longer be required to obtain consent for treatment payment. A patient's refusal to consent for something we don't have to get the consent for. So if you're implying outside of TP&O, treatment, payment, and healthcare operations, I think that that's something we're happy to work with you on.
Senator Jensen.
Madam Chair, could I ask council to speak to this amendment and how they see it intersecting with Ms. Hooper's questions?
Ms. Kavanaugh.
Madam Chair and Senator Jensen, for the first part, it's my understanding, it might be a little bit confusing, but it's my understanding that you still have that the departments could release records if they're authorized by law in other sections. So this would not change that at all. The second one is that I think if they don't have to, consent, that's fine. I mean, it's when if they refuse to sign the consent, if they don't need the consent anymore, then it wouldn't apply.
Senator Jensen.
Thank you, Madam Chair, and thank you, Senator Pratt and Ms. Hooper. My understanding is that line 1.3 only applies to the this would only modify the new exceptions that Senator Pratt's bill produces. And I think that's consistent with what Ms. Kavanaugh said as well.
Ms. Hooper.
Senator Benson and Senator Jensen, I think as long as we are permitted to disclose when we're already required to under federal and state law, then the amendment would probably be fine.
Senator Abeler to the amendment.
To the amendment, and part of this is my comments to the whole bill. Senator Jensen, I recognize what you're trying to accomplish. Not that actually, I'm praising your intent, and I think that actually Mr. Neumeister was talking about the effect of the bill, and he knows enough not to go into people's heads. But this bill is amongst the worst pieces of legislation we've done in a long time. It will open up people to all kinds of harm. And ironically, the comfort this is meant to provide, to not give it to the Department of Health and Human Services, are one of the few entities that will be released to that we actually trust. I actually took the time to read, what is it, that's section, this rule, Title 45, Part 164, subpart E, and I discovered that this information can go anywhere. There's a covered entity. They can give it to another covered entity. They can give it for these purposes, payment healthcare operations. If you're an entity in a healthcare arrangement with Senator Jensen, you can imagine what that term means. It's like any arrangement, be it IHP, HMO, you're a provider, you're doing research, and to other participants in other healthcare arrangements. That's what subpart E talks about, in terms of what they can do. It talks about work-related illness and injuries, that can be disclosed. This information can be given to public health entities about public health activities, which is not the Department of Health. And it can even be used to prevent serious harm. And as you read, that's just like a few of the points of 20 or 30 that are in there. And so having the Department of Health now, I would rather we give it to them. At least we know that they're acting in Minnesota's interest. We can discuss whether or not that they're that we like them with all our data or not. But this, and as one of the testifiers mentioned, these operations could be offshore. And so I just want to help you understand what you're doing and what you're not doing. You're almost doing nothing about limiting the flow, the exit of data that this federal rule allows. And especially when you go into the operations component, for your treatment and payment, then at least you're narrower. And I just want to point out that this doesn't give you the protections that you seek. And I know you're trying to make sure that nothing bad happens, but this expands the potential use of this data and the potential loss of this data in proportions not yet seen. And so I just wanted to offer you that advice. Thank you.
Senator Jensen to Senator Abler's point.
Thank you, Madam Chair. Actually, I was going to ask Senator Pratt to Senator Abler's point.
Senator Pratt.
Well, thank you, Madam Chair, and Senator Jensen and Senator Abler. It kind of goes back to the point in my mind that Senator Klein raised early on, and I wrote a note that I'm happy to look at some of those operations that maybe go a bit too broad, because when I read the very same definition of operations as a layperson, right? Conducting quality assessment and improvement activities. Of course I want people doing quality assurance, reviewing the competence and qualifications of healthcare professionals, underwriting, enrollment, premium rating, conducting and arranging for medical review, legal services, and auditing functions. All of these seem to be in the best interest of the patient. I do applaud Senator Jensen's intent and agree with Senator Jensen's intent, as I understand his intent here from our conversation, so I don't mean to infer, since I've lost my temper before, that I don't want the state knowing my personal health information unless I want them to know it. This is not about opening it up very, very broadly. I don't want them to know that I have some form of cancer unless I decide that I want them to know I have some form of cancer. And Senator Jensen, we talked about some questions. I don't remember the term that you had for those, but I don't know that I want the state to know that either, whether I have firearms in my house or whether I feel safe at home, or some of those other questions that are very, very personal. They're really meant for a physician to protect a patient then and there, not to be shared very, very broadly. And so as I recall our discussion, that's how I interpreted the intent of this, and I agree with it.
And to the A1 amendment, we have a representative from the department, and I'm going to have the department come up and comment. And then I'm kind of started a new list to the A1, so I've got Senator Marty on the A1 amendment. Welcome to the committee.
Thank you, Madam Chair. For the record, my name is Melissa Finnegan. I'm the Legislative Director of the Department of Health. Having just seen the A1 amendment and trying to slot it into the bill and what it does, I think Senator Abeler said it very well. We would have potential concerns about unintended consequences of this language of data that we currently receive for public health purposes, such as mandatory reporting laws related to infectious or communicable diseases. And I would want to be able to run this language past the experts at the department to make sure we don't have situations like that happening where we would no longer be able to receive that data and protect Minnesotans.
I do have, this doesn't modify the infectious diseases section, so I think we need a little bit more checking. It doesn't impact infectious diseases. Senator Marty.
Madam Chair, I just wanted to request we divide the amendment between 1.4 and 1.5.
Senator Jensen, there's been a request that the A1 amendment be divided, so you get to pick what we vote on first.
I'm fine with taking them in order and separating them.
Okay. To the divided amendments, lines 1.1 through 1.4, actually, we're going to need to include 1.5. Senator Abeler, comments?
Yeah, actually just to a comment by the author. Senator Pratt, you said you don't want your cancer reported to people without your consent. You don't want people to know what you're doing without your consent. This bill is about giving hundreds of thousands of people access to that information without your consent or knowledge. And that's the bill. Under Minnesota law, there's 3 ways they can give, your information can be released. One is if you sign a piece of paper and says, I authorize it. The second is if you hurt yourself at work, and there's other statutory ways where they must release it. Or if someone affirms that you've told them it's okay to get the information. And you can have a cause of action against people if they violate that. The second half of this amendment, which we're not on right now, is almost moot because there's almost nothing you can't consent about. Because you're now at the whim of a federal regulation, which by the way could change even, but now we're looking at it as it is today. But if you take the time to read the 2 pages of description of health operations in mosquito print, it even includes fundraising. It even includes customer service and for what purposes they might find and research. And so I just want to caution you that your very stated purpose is that, anyway, so I just want you to, I'm reacting to your comment and, you know, you're the author, you like the bill, but I'm cautioning you about what we're asking for because it may not be what we think we're getting, providing comfort without any substance, and I can vote no.
Madam Chair.
Madam Chair.
Senator Pratt, to the author, Senator Pratt.
Thank you, Madam Chair, and Senator Abeler, and you touched on 2 points. One, I didn't say people, I said the state, right? I don't necessarily want the state government to know my medical afflictions. What I do want is I want my provider to be able to share the minimum necessary information so that my treatment is paid for, that when I make an appointment and I go somewhere that I can, that I own my data and it's being shared in my benefit, right? So it's not about spreading it out. I also have a definition of healthcare operations, which I looked very briefly, seemed to align with Ms. Brase's, and my glasses aren't as good as hers, so I had to print it out in bigger font. But I think what you brought up around fundraising and some of the others are definitely not what the intent is to do. Quite honestly, I've been looking through this and I don't see it in my definition of healthcare operations in 45 CFR 164.501. And that goes to the point that I'm extremely willing to look at certain exclusions around that because the intent is to make sure that health records are available for ensuring that the patient's needs are met. And I would agree with you, I don't think fundraising are in the best interest of the patient.
Senator Abeler.
And I appreciate that. What you're looking at, Senator Pratt, is a summary. I was actually reading the base text in the federal regulation, which you wouldn't think to bring up some of the, if you summarize it, you have the whole 2 pages of mosquito print. So just to tell you. So, and thanks, I'll stop.
Senator Jensen to the first part of the divider amendment.
Madam Chair, a few hours ago I presented a bill to a different committee and I expected it to be 10 minutes and the conversation proved to be very fruitful for 2 hours. And my bill got better. I don't think my amendment accomplishes what I had hoped it would. I would like to withdraw my amendment, both sides.
Okay. Senator Jensen withdraws his A1 amendment. I will say that in reviewing the handout on CFR 164.501, I do see population-based activities, which tells us the Department of Health would be very interested in this information. So Senator Jensen withdraws the A1 amendment. Now back to the list, Senator Kiffmeyer.
Thank you, Madam Chair. Senator Pratt, I don't question at all your intentions or your motives, but I do get to question your bill and what it does. And so here, in regards to a statement you just made, that I do not want them to know my personal information. In fact, you're actually speaking against your bill, because this bill, when you align Minnesota with the HIPAA language, is exactly as Senator Abeler has said. HIPAA is not about consent. HIPAA is about sharing, wide, broad sharing. Matter of fact, permits broad use and disclosure of individually identifiable, protected health information without patient consent. According to HHS, in a 2010 rule, more than 2.2 million entities can have access to patient data without consent. HIPAA is about sharing, broadly sharing, not about consent. Minnesota's privacy record laws, our health record law, is truly about consent and does what you just spoke to. You don't want them to know unless you say so. But then you want to stand for Minnesota's Health Record Act, because that's what actually does it. Minnesota's Health Record Act also has medical emergency. It also has other providers within related healthcare entities when necessary for treatment. Patient unable to consent to an in-state or out-of-state healthcare facility described in 144A Minnesota law. For sharing a deceased patient's records to providers treating a deceased and surviving adult children. Minnesota's health record law is a consent law that protects us and the best in the country. HIPAA is about sharing. There is no consent if you align with HIPAA. And not only sharing, it's a no holds barred, open the gate, everything goes out the door, and you have totally lost control. Because when it goes to one of those 2.2 million, they will then have the right under HIPAA to share with one of the others, and it just goes round and round in a circle. And I think that considering all the questions that are now asked in a doctor's office by current law, guns in your home, do you feel safe, different things like that, this has great potential. Then on top of that, you have the language that has to do with the clinical, I'm just trying to find the exact wording here, that is in it, healthcare operations and clinical guidelines. And I don't know if you're aware, Senator Pratt, but there is a bill, not a bill, but a court case, I believe just from last week, which had to do with United Behavioral Health. And United Behavioral Health was actually ruled against by a federal judge that it breached its fiduciary duty to patients by using unreasonable and overly restrictive guidelines to make coverage decisions for tens of thousands of mental health and substance abuse patients. And so we have to realize that if it weren't for Minnesota's Health Records Act, this kind of court cases protecting your privacy, HIPAA does not protect your privacy. HIPAA is about sharing data. Minnesota Health Records Act is about protecting your privacy. But I'm just speaking to the fact that by your own comment, you would want to keep the Minnesota Health Record Act, if that's what you want to do. If you'd like to comment to that?
Thank you, Senator Pratt.
Thank you, Madam Chair, and Senator Kiffmeyer. And I think you're touching on one of the one of the things that's been most tricky about this, why it's something that's taken over a year to get to the point where it's at. Certainly, I don't want to put anyone's data at risk, but I want to make sure that when I hear stories like Mr. Buermann's, where our extra steps get in the way of his treatment, get in the way of him owning his health record information, then to me that says that with all the best intent, maybe there are some options here that allow us to do a better job. If we can streamline the payments, if we can help facilitate the transfer of records between providers. I mean, we're not, again, you know, if we need to take a look at the operations where the most of the debate seems to be, I think we can be very clear as far as what those constraints should be. If I want a clinic, but I certainly want my health information to be reviewed to decide whether or not the diagnoses and the procedures are correct, whether there's quality assurance within the clinic and the system. You know, those are all things that when I looked at operations that I saw. I want to honor the Minnesota Health Records Act, which is why we took this specifically to these three pieces. And as I've asked this bill to be drafted, and as I've been looking at it, and maybe, you know, Senator Abeler's right, maybe I'm not looking at the root. I've tried to do my research. I've got a stack of it here that says that I, as a patient, can even choose to opt out from disclosure. But, now I talked myself on my own train of thought.
Senator Pratt, we have quite a list.
Yeah.
I'm guessing the issues will reemerge.
I just want to follow
Senator
up with
Kiffmeyer, follow up.
Yes, thank you, Madam Chair. And so, Senator Brad, I realize your good intentions, but the facts are the facts. HIPAA is about sharing. The Minnesota Medical Health Record Act is about consent and privacy. The other thing that really concerns me, you mentioned operations. That exactly is for the gentleman that came and testified. It is about operations, not about changing the whole underlying consent and the wonderful things that come with the health privacy, but it is about the operations. And I want to tell you, the entities out there are doing wonderful things and are really growing in a great way in their operations. A lot of this is an operational issue, not a law issue. And you have California to Minnesota, now you have 2 state laws. And so yes, you're probably going to have some extra questions that go along there, but I think it's not that. I think the other thing that we should focus on that more than anything. But also my concern is this: if you cannot assure patients a privacy with their health data, my concern is they may not go for health care or may not be as honest with their doctor, for they're concerned that this knowledge and information will go way beyond where they ever wanted it to, and then it's too late to pull it back. Once you go out this, you cannot pull this back. Once all that data is out there, you cannot do that. My concern is those patients need to be able to be honest with their healthcare providers. They need to not go in wondering, will I be saying something that later, by my own words, could be used against me in some way that I have no control over. That is not good for Minnesota's healthcare system. That is harmful to patients and also does not fulfill the whole purpose of having a healthcare system, is to think of the patient first and do no harm first. And so I cannot support this bill, and I would not be able to support it unless, or in any case, because I think it has been explained to you by my comments already. So I just wanted to be straight and be on the record in regards to my heavy concerns. Indeed, all the small print. You don't just get to do your talking points, it's got to be all the small print goes with it. That's the hard thing. It is really hard, and I cannot support that.
Thank you, Madam Chair and Senator Kiffmeyer, and I apologize if I seem to infer that I was maybe I have a different perspective on this, right? Because as I was looking through it, I didn't see from HIPAA that this is how we share data. It became a framework for how we protect data and how we can disclose it and who we can disclose it to. And we can decide whether, and we as a state can decide whether or not there are certain functions within that that we want to exclude. As I mentioned in my opening remarks, this should not change how we share information for research. This should not be. This should not change how we. It does not allow for any sale of information that doesn't already exist today. And I've been able to confirm that it still allows a patient right of action. We're not taking that away in this. We're, quite honestly, the version from last year did. I've been open. I talked to Mr. Flanders last year, but Mr. Neumeister, Ms. Brase have never contacted me about specific concerns regarding the bill. And as you know, I'm always open to trying to make bills better. I just need some feedback.
Madam Chair, I just want to clarify one quick moment. I didn't mean to say talking points. I just meant well-intentioned, but statements don't have the force of law.
Mm-hmm.
All right.
Thank you.
Thank you. And Senator Abeler, Senator Marty, Senator Haley. Senator Abeler.
Well, thank you. And this is a really good kind of hearing to have. I think we had some good testimony, some good dialogue, and I think the author is listening. And I'm going to have a couple comments, and I have an amendment which might help us move this bill to a safer place. But at the end, it's short. And so, to the worthy good that we all seek, everybody wishes, Senator Pratt, that it could do the good things, that our laws could do the good things you seek. Your testifier with the monthly thing he gets. Our law maybe needs a tweak. There's three ways we can get information transferred, I mentioned, by wet signature, by law, or by affirmation. The problem is that some of the hospitals don't trust an affirmation. Okay, well, let's work on that. But the protections that we have currently are the envy of people who want to be left alone. And so if you, again, referring to the rule that we're talking about, many things can be given. And so if you haven't heard about data breaches, you're actually an expert on this topic about data much more than I am. In the weekly in the paper, there's a data breach by somebody. And so this information, you want to ask, to whom can this information be given based upon the rules here? It is so flexible to who can get it. It's even, if you, like a Department of Health grant, as an example, a grantee, or any public agency, including employees or agents of the public agency or its contractors or persons to whom it has granted authority. It's even the subcontractors of contractors. And information that might be something about you, and it's not what we intend. And there was just a case with it was United Behavioral Health, where they used information to deny care. I've got 40 years in my practice, I've heard that a number of times. When I first got in practice, I used to advise my patients when they come in, if they suffered a work injury, to file it. We would do modest care and get them on their way and not make it a big deal. Nowadays, I tell them not to. Do you know what's currently against the law to discriminate against a worker for a work injury and not hire them? In practice, do you know what happens? They don't get hired. Somebody knows that you filed a work claim. And so that's how we are with the current law, and it's against the law. When there will be a list that somebody will, because there's going to be so many hands that could touch this data, I will predict that somebody will create a list of people with mental illness. And one of the things you can give is the clinics you've been to. It's in the list. It's right on the second page of operations. And they will assemble a list of people with mental illness, or with AIDS, or with some kind of cancer because they went to some cancer clinic. And when you go to get a job, that self-employed entity is not going to hire you, or you're not going to be hireable. because this information gets out. And if you read 164 and all the subparts, it says must release. And I just want to caution you, this is not what you need. And I don't think we want treatment this operations part of that. At the very least, that is so problematic, and it's beyond the intent of everything you and your witnesses have talked about. Every case I've heard about, I've been following this for a long time. I was part of 2007 when this was first brought into existence. And I was concerned then about the affirmation part. This is like the good old days. And so I could go on, but I'm not trying to prolong this here. But modernized, safe, and efficient, and everybody's gonna know. And if you recall what happens when people get nervous about their data getting out, they don't go for care. And this is not going the right direction. And so Senator Pratt, I mean, I'm trying not to even say too much, but I know this topic, and I know what we intend, and I know the pride that our predecessor had, Senator Peterson. He'd be doing the same talk as me. And so I think just to move this into a better place, I'm going to move that on line 1.13, after treatment, we insert the word or, and then after payment, we just delete or healthcare operations. And I think that moves this bill to a better place. And so now you're talking about treatment and payment, which is everything you and your witnesses and testifiers have said. And then it just gets sorted out of the way to the judiciary. I think then maybe we can make sure this is narrowly focused to do only the good things we intend. So I'll I'll listen for your response.
Madam Chair.
Senator Pratt.
Thank you, Madam Chair and Senator Abeler, and thank you for that. And I'm a bill author that likes to dig in and try to find some things, but obviously your expertise allows you to see some things that maybe I miss, or as a layperson I look at differently. Madam Chair, rather than accepting Senator Abeler's amendment, what I'm thinking is, given that we've had some concerns voiced by Senator Klein, by Senator Jensen and Senator Abeler, it might be best to table the bill and continue to work on it. It's not something that's required for the budget going forward. I think it's good policy. I think we're all on working towards the same goal. But I think what we've done here is started a really, really good conversation about what's in the best interest of patients, and that's what we're all here for. Having worked 10 years in fraud and fraud prevention and dealing with identity theft and looking at data security, there are some things that I feel very, very comfortable with Senator Abeler. But I want to make sure that stories like Mr. Buermann's are also recognized as well, and that our law shouldn't be getting in the way of effective treatment.
Senate File 1575 is on the table, and we are going to take a 5-minute recess. Senator Pratt, I'd like to speak with you. We are in recess for 5 minutes.